So hi everyone, I wish I could be there in person to talk to you today, but we are going to do this via Zoom instead. So I'm going to see if I can share my screen with you here. So what we're going to talk about today is atrial fibrillation. But to give you a little bit of background first, my name is Ulrika Birgersdotter-Green. I go by Ricky Green for short. I am a professor of medicine here at University of California, San Diego, right around the corner from you. I'm in the division of cardiology. And specifically in actually the division of electrophysiology. So here we are. This is me on the left side there, showing one of our fellows how to put a pacemaker in. And in the other picture, you can see our faculty of electrophysiologists at UCSD from a couple of years ago. So what do we do then in electrophysiology? Well, again, we are under the division of cardiology, so we're all cardiologists. We specifically specialized in treating heart rhythm problems. And I give an example here, atrial fibrillation, sudden cardiac death. We are the ones putting pacemakers in and defibrillators in. So I thought what we will do today is specifically talk about atrial fibrillation, because this is really, really a big issue and something we see so much of. Atrial fibrillation is in fact the most common arrhythmia that we see in clinical practice. 2.3 million people in North America with atrial fibrillation. It accounts for 33% of all hospitalizations for any arrhythmia problem. And this continues to go up and up. So over the last 20 years, admissions for atrial fibrillation have increased by 66%. This is also a disease that is related to age. So demonstrated in this slide here from 4 different studies, really from across the world. You can see that the incidence of atrial fibrillation rises sharply as we get older. So from age 65 to 70, it goes rapidly up among the population. What are the risk factors for getting atrial fibrillation? High blood pressure, very much one of them. Having heart failure is a risk factor. Having diabetes is a risk factor. As we talked about, getting older in and of itself is a risk factor. Having problems with your thyroid may contribute, and in general, having heart disease, such as blockages and stents and a bypass surgery will also increase the risk of getting atrial fibrillation. And this is what atrial fibrillation would look like on an EKG. And what you can perhaps appreciate here is a lot of little squiggly lines, and if you zoom in a little closer, you can kind of see that it typically goes, the heart rate is fast. Each spike here demonstrates a heartbeat, showing that when a patient goes into atrial fibrillation, the heart rate tends to go up and the heartbeat tends to become very irregular. There are a couple of different types of atrial fibrillation. You can have something called paroxysmal atrial fibrillation, which means that it comes and goes, but it stops by itself every time and should last less than 7 days. If you have persistent atrial fibrillation, a patient goes into atrial fibrillation and will not go out of atrial fibrillation by him or herself. So this would need the patient to come in and get something called a cardioversion to stop the atrial fibrillation. And then you can have permanent atrial fibrillation, or what we can kind of call accepted atrial fibrillation, meaning it's there. We tried to get it to go away. We've tried to maintain normal rhythm, but it's not possible. And that patient is then in permanent, or you can also actually call it chronic atrial fibrillation. So let's look a little bit where this atrial fibrillation comes from. So here is the electrical system of the heart. You have, if you just look at the heart here, the 2 top chambers of the heart, the atria, and then the 2 bottom chambers of the heart, the ventricles. Atrial fibrillation is a heart rhythm disorder of the upper chamber of the heart. So normally, the electrical system always starts up here in the sinoatrial node, up in the top right chamber of the heart. This little spot there fires and regulates your heart's rate and rhythm. And it should normally conduct down a very distinct path from the SA node right here to the AV node, and then it goes to both the ventricles, sends an electrical impulse, and now the heart beats. So that happens every time your heart beats. Starts up here, works its way down to the bottom chambers of the heart, and then the heart squeezes. Now, what happens when you have problems with the electrical system then? So if it is in the bottom chambers of the heart down here, you have something called ventricular tachycardia or ventricular fibrillation. This is truly bad news because this is essentially the same thing as the heart trying to have sudden cardiac death. That is, however, not what we're talking about today, because today we're talking about atrial fibrillation, which is a heart rhythm disorder in the upper chamber of the heart. So in atrial fibrillation, we can go back here, the sinus node up here no longer regulates the rate and the rhythm, but rather the rate and the rhythm becomes kind of fast and chaotic and regulated from a lot of different spots. So you can kind of see here that instead of having one spot up here doing it, you have a lot of little organs firing, creating this fast, irregular heart rhythm and heartbeat. And why is this bad? Well, first of all, of course, because most patients who go into atrial fibrillation don't feel that good. You are symptomatic. You can feel this fast heartbeat and the irregularity. There are patients who doesn't feel the atrial fibrillation, and sometimes as you get older and in fact get used to it, you do adjust to it and it becomes less symptomatic. But most patients would certainly feel that something isn't quite right. And those symptoms can range from, oh, I feel like my heart is beating a little fast, to, oh, I can't even walk up the stairs anymore because my heart is beating out of my chest. So patient symptoms and heart rate are two very important things when it comes to why we should treat atrial fibrillation. And the other big point with atrial fibrillation is that it can increase the risk of a stroke. So let's look a little bit and when we see patients in clinic and talk to patients about atrial fibrillation, what are the things that we need to talk about? This is a little bit of a busy slide, but I'll take you through the high points of it. So over here in green, we talk about rate control. So you remember how I was saying that the atrial fibrillation can be very fast. So what the patients primarily feel is not always the irregularity, but the fact that it's going fairly fast. So certainly we would always think about how can we make sure that we get the rate down so it isn't as bothersome. And there are many medications for that available, including the oldest medication still around that has been here now for over 100 years, and that is digitalis, that is actually still used for this very purpose. The next thing that we want to talk about is, well, what can we do to maintain it? SR stands for sinus rhythm. How can we get that little sinus node back in action again and get the atrial fibrillation to go away? Here we have two options. We can use medications, and we can use what we call non-pharmacological, meaning more procedure-oriented ways of maintaining normal rhythm. If we're going to go with medications, we have several anti-arrhythmic medications that we often try first before we go into the more advanced or more procedure-oriented options. And specifically, the one we're looking at here really is to do what is called a catheter ablation. And I'll come back to that a little bit more. The other thing that we also always talk to patients about is, what is the risk of a stroke for you, and what can we do to reduce the stroke risk? And being that in a sense is kind of the most important component of atrial fibrillation management, I do want to talk a little bit more about that right away. So why would we have an increased risk of stroke in atrial fibrillation? Well, if this is an ultrasound picture of the heart, and this is the left upper chamber here, it's called the left atrium. And you see this big thing here, and sitting in this little appendage here, these are clots. So clots can form in atrial fibrillation, and there are multiple reasons for this, but clearly we over and over again see that we have this increased risk of clot formation in atrial fibrillation. There are certain things that drive that risk, and we talk about this so-called Chad's VASC score. And for each patient, we would look to see what is that patient's risk. Does the patient have a history of heart failure? You get a point for that. You have a history of high blood pressure, get a point for that. Are you 75 years old or older? That's a 2 point. Do you have diabetes? 1 point. Have you had a risk of stroke in the past? 2 points. Do you have a history of vascular disease? And that would mean, say you have had stents in your heart as an example. You've had a heart attack. You get a point. If you're 65 to 74, you get 1 point. If you're 75 again, remember you get 2 points. And if women have a slightly increased risk, so being a woman gives you another point. And this is a time when you do not want to collect points here, quite the opposite. So the higher the number of points seen here in bright red, the higher your risk of getting a stroke is. So we look at this Chad's VASC score in all patients to see what is the risk of this patient to have a stroke. And then what do we do about that? So under those circumstances, we need to talk to a patient about should that patient be on a blood thinner or not. And we have learned a lot over the last few years about blood thinners. So first of all, let's just look at aspirin. So this is antiplatelets here. So aspirin is probably a little bit better than taking nothing, or in this case, they compared it to placebo. So a little bit better, not dramatically so, but sure, a little bit better. Then the next study then is say, okay, let's compare aspirin to aspirin and Plavix. Is 2 medications better than just aspirin? Again, we're a little bit better. Next step would be to say, let's compare aspirin and Plavix to warfarin, or the trade name is Coumadin. This is the original blood thinner. This is the one that for 30 years was really the only truly effective blood thinner we had. And a lot of patients over the years have been on warfarin. And now we're starting to see impact here, that clearly warfarin is better than what we call antiplatelet agents. So now we're moving towards clear risk reduction. And about 10 to 15 years ago or so, we started finally, I would like to say, new medications that have over time more or less replaced warfarin or Coumadin. Here's an example of what I'm going to call a new medication. It's not so new anymore. It's been around for a long time now. Dabigatran, the trade name is Pradaxa. So now compared to warfarin to dabigatran, and dabigatran is better. These are the two even more recent one. Rivaroxaban is Xarelto and apixaban is Eliquis. And again, compared to warfarin, all these newer blood thinners are across the board better. So over time, I think what we have clearly learned is that we can reduce the risk of a stroke for patients. And the new medications, the newer medications such as Xarelto and Eliquis, they really do a very good job, very good job. And however, of course, for all patients, you also have to weigh that this slightly increased risk of bleeding. So this is a challenge that we have with some patients, is that some patients have a higher bleeding risk, but that same patient typically also has a high risk of a stroke. So we always have to adjust these kind of things, and nothing is ever written in stone that you have to be on Eliquis for the rest of your life. You know, if there comes a time when the bleeding risk is too high, then perhaps that isn't the time to be on a blood thinner anymore. Now, there are some new procedure opportunities for reducing the stroke risk as well. So back to this echocardiogram, this ultrasound picture. So here, this is again the left atrium, and you can see this little V-shaped formation here. That is the left atrial appendage, a structure left to do really no good. It serves no purpose for us. And unfortunately, the only thing that it does now, it's like the perfect little nidus for a clot to form. So over the last few years, what we have learned is that if we can isolate that appendage so that no clot can go, if a clot is formed, it can no longer leave that appendage, you can really reduce the stroke risk. And you can see what this looks like here. It's like a big umbrella or similar that you then put into this appendage. So you can see here, this is a big vein, and you go in from a big vein in the groin. You come up in this big vein, you go into the right upper chamber. We need to cross over. So you cross over, you make a little puncture hole between the wall of the right upper chamber and the left upper chamber. You go into the left upper chamber. Here is the little appendage that does no good. And you place this umbrella-like structure in here to seal this off. And then it's sealed off and you pull everything back, and the clot can't get out. This is typically today used for patients who can't take blood thinners because they have had, you know, massive bleeding type things. And works very well. It's not 100% guaranteed to not have a stroke or clot formation, but it does work well. You can also see that it's a fairly invasive procedure, so it's not necessarily something that you want to jump into without having a good discussion about it. There are some other treatments for atrial. Excuse me, going back here saying, what can we then actually do to treat atrial fibrillation other than medications? So in the operating room, you can do something called a surgical MACE procedure. This requires an open chest procedure. This is not something that we do unless it's needed, unless it's absolutely indicated, and usually in the setting of needing other things done, such as bypass surgery. If you have atrial fibrillation and it's going really, really fast and there's no other way to treat it, you can actually go in and you can do an ablation of the AV node. That's the point between the top and the bottom chamber of the heart. You can go in with a catheter. You can cauterize the AV node. So now impulses can't go from the top to bottom anymore. So you no longer really are symptomatic and you no longer have to worry about the fast heart rate, but you do now need a pacemaker. And we certainly do this sometimes, and it's very effective. The ultimate treatment for atrial fibrillation is doing an radio frequency ablation, namely cauterizing actually the AFib spots. So that is something that has really come a long way here. Again, going back to the electrical system here, where would we, if we did the pacemaker option, we would go in and we would ablate right here, the AV node, and no, nothing would conduct from top to bottom. But what's going to make the bottom beat? Well, that would be the pacemaker that we put in. On the other hand, if you want to try and do an AFib ablation, you're going to go look at where does the AFib come from here in the upper chamber of the heart. And what we have learned over time that in almost all patients, the atrial fibrillation originates up here in the left upper chamber of the heart. So we know the spots, we know the trigger points at this point, and that's where we can go in and target with an ablation procedure. And we have a lot of advanced mapping to show us where it is. These are catheters inside the heart. And what you are doing, you're essentially saying, I want to do a super precise EKG from the inside of the heart, and I can look to see where the trigger spots for the atrial fibrillation is. So this is the patient. Each spike here is an AFib beat, and it's going pretty fast here, as you can see. We want to go over to the left side of the heart, so we use ultrasound, and we cross over. So here's an example of crossing over from the right to the left side, making a little hole in the wall here. This heals up once everything is out. And then you have a lot of different techniques now to go in and look where these spots are. This is an example of a Lasso guided ablation here from the pulmonary veins. This is ESI mapping. Again, we want to, this is the left atrium. Here are the pulmonary veins, and the spots that triggers the AFib sit right here. And these are here, we have been ablating right in these areas here. And if you have a successful ablation, you can see, boom, suddenly here the AFib terminates, and this patient here is back in nice, normal, regular rhythm. Ending this talk, though, I do want to bring something up that I think is very important, and that is that there are things that we as people, as patients, can do. So lifestyle modifications really do help reduce our overall risk of getting atrial fibrillation or making the atrial fibrillation worse. So no smoking, and this is true, I'm going to say, for heart disease in general. Like, the worst thing that we can do for anything heart related is smoking. And I usually say to my patients, everything really can be done in moderation. You like to eat a nice good steak occasionally, that's completely okay. Certainly nothing wrong in having a glass of wine. You can't smoke, though, and even one cigarette a day is too much. So no smoking. Managing high blood pressure is also really important. And why that is important is the higher your blood pressure, the more the increase the risk of dilating the upper chambers of the heart where the atrial fibrillation comes from. And when the upper chambers of the heart get bigger, the risk of atrial fibrillation also gets bigger. So high blood pressure management, really important. Exercise, fantastic, always for everyone. And this is also something that I talk to my patients about, is that, it's all great that we all exercised when we were 25, but the fact of the matter is we need to exercise when we are 75 and 85, and it's so important to continue to do that. And when you're 25 and you stop exercising, you bounce right back. If you are 80 and you decide that, my daily walks are just getting too much, it's so much harder to gain back what you're losing. And when I say exercise here, I don't mean that anyone should go on and run marathons. That's not needed. It's just we gotta stay in motion. And weight loss when needed is also helpful. So these are all the things that we can all do to help our heart health in general. So in conclusion, atrial fibrillation that we just talked about is the most common heart rhythm problem on earth. Most patients with atrial fibrillation are at risk for a stroke. And when you have a stroke, they can be large and disabling if they're related to atrial fibrillation. So anticoagulation, which is blood thinners, that really is the mainstay of treatment. We have left atrial appendage closure. Those were the little umbrellas that we talked about when anticoagulation is not an option. And doing the radiofrequency ablation procedure can be very successful in treating atrial fibrillation and in the appropriately, of course, selected patients. And then again, don't forget that lifestyle modifications always helps. So, I think we've come a long way, right, from what the stethoscopes look like in the 1800s. So thank you so much for listening, and I hope this was helpful. We are here for you at the UCSD in the cardiology, in electrophysiology. We would be happy to see you. Thank you very much. Bye-bye.